one, we will talk about 2025 guideline for the prevention, detection, evaluation, and management of high blood pressure in adults. Part 3 of 3. Diabetes. More than 80% of the adults with type 2 diabetes have hypertension. The prevalence rate of hypertension in adults with type 2 diabetes is double that of age-matched adults without diabetes. The second is very important. Cardiovascular disease risk in adults with both type 2 diabetes and hypertension is more than double the risk of either condition alone. So having type 2 diabetes and hypertension further increases the risk of cardiovascular disease. Hypertension accelerates chronic kidney disease, particularly when moderate and severe albuminuria is present. So having type 2 diabetes along with hypertension increases the risk of cardiovascular disease and chronic kidney disease. And 80% of the adults with type 2 have hypertension. So it is very important combination one should know about. These are all the recommendations based on 2025 guidelines. Number 1, in adults with type 2 diabetes and hypertension, antihypertensive treatment needs to be given to reduce systolic blood pressure less than 130, with an encouragement to achieve systolic blood pressure less than 120. It's very important. All those patients with type 2 diabetes with hypertension need to have lower systolic blood pressure less than 130, preferably less than 120. The second, in adults with type 2 diabetes and hypertension, antihypertensive treatment should be initiated to reduce the diastolic blood pressure less than 80 if it is more than 80. So the blood pressure has to be less than 130 and less than 80, preferably less than 120 and less than 80. Third, in adults with type 2 diabetes and hypertension, all the first-line classes of antihypertensive agents are useful and effective for BP lowering. The first-line classes of antihypertensives are, according to the new guideline, thiazide-type diuretics, long-acting calcium channel blocker, like only the dihydropyridine group, ACE inhibitors, and ARBs. Fourth, in adults with diabetes and hypertension, ACE or ARB are recommended in presence of chronic kidney disease with the GFR less than 60 ml or albuminuria more than 30 milligram per kilogram should be considered. It delays the progression of diabetes-related kidney disease. So one should remember ACE inhibitor or ARB should be given, but should not be given in combo. So keep in mind. The second group is obesity and metabolic syndrome. Obesity is a major modifiable risk factor for hypertension, with a great degrees of adiposity associated with higher BP levels. Metabolic syndrome has been associated with increased risk of cardiovascular disease. Metabolic syndrome has increased in recent years with an estimated prevalence of 47% of adults. Regardless of weight loss strategy, weight gain is common, may lead to rebound worsening of blood pressure. As we mentioned earlier with diabetes, obesity is affecting 50% of US adults. The hypertension along with obesity, which is common, and it has a profound effect on cardiovascular disease. The recommendations are as follows. 1. In adults with hypertension who also have overweight or obesity, GLP-1 receptor agonist for weight management needs to be given along with antihypertensive medications. In adults with the BMI more than 35, bariatric surgery, when considered for weight loss, in combination with behavioral intervention and antihypertensive therapies may be effective in lowering BP. So when you are dealing with BMP a BMI more than 27, GLP-1 receptor antagonist plus antihypertensive medication. If it is more the BMI more than 35, bariatrics, surgery, behavioral intervention, and antihypertensive therapies. The third category is chronic coronary disease. Adults with chronic coronary disease and hypertension increase risk of death with, with adults than who do not have hypertension. The goal? Reduce the systolic blood pressure less than 130. What are the drugs needs to be used? AC inhibitors, ARBs, and beta blockers. If additional antihypertensive medications are needed to achieve BP control, calcium channel blockers, dihydropyridine group, thiazide diuretics, and or MRA, which is mineralocorticoid receptor antagonist. Next category is prevention of heart failure in adults with hypertension. In patients with heart failure, 71% of the patients have hypertension. Especially when the hypertension starts in less than 40 years of age, highly associated with the development of heart failure. There is a dose-dependent association too. Higher the BP level, the higher the chance of heart failure. The long-term treatment of systolic and diastolic hypertension has been shown to reduce the risk. The meta-analysis of clinical trials support BP control rather than a specific medication class to prevent heart failure. So, reduction in hypertension paramount to treat patients with heart failure and also to prevent the heart failure, especially if you identify hypertension early on. Recommendations are as follows. 1. In adults with hypertension, treating systolic blood pressure less than 130 is recommended to lower the risk of developing heart failure. Recommendation 2. In adults with hypertension, treating diastolic blood pressure 80 is recommended to lower the risk of developing heart failure. So, need to reduce the systolic blood pressure less than 130, diastolic blood pressure less than 80. Those are all class 1 recommendations. Next group, heart failure with reduced ejection fraction. Hypertension is the most common morbidity in patients with heart failure with reduced ejection fraction. They define reduced ejection fraction as left ventricular ejection fraction is less than 40%. Hypertension is known to be a major risk factor for heart failure with reduced ejection fraction. It happens because it alters the cardiac structure in response to chronic pressure overload. The goal in this category also reduction in systolic blood pressure less than 130. In this particular group, when they have a heart failure, diuretic should be added if you think the patient has a volume overload or any evidence of volume overload. Dihydropyridine CC, calcium channel blockers, may be used despite the optimization of goal-directed medical therapy. I need to mention this one. The non-hydropyridine calcium channel blockers may be harmful in patients with heart failure with reduced ejection fraction because they have a negative inotropic effects. What are the goal-directed medical therapy for patients with hypertension with heart failure with reduced ejection fraction? One is beta blockers. In patients with reduced ejection fraction, if asymptomatic, use one of 3 beta blockers have been shown to reduce mortality and hospitalizations like bisoprolol, carvedilol, and metoprolol succinate. Next class is MRA, mineralocorticoid receptor antagonist. In patients with symptomatic heart failure with reduced ejection fraction, spironolactone or eplerenone is recommended to reduce morbidity and mortality if GFR is more than 30 ml per minute and potassium is less than 5 milliequivalent per liter. The MRA class tend to increase the potassium, so be careful and also monitor the electrolytes, especially in reference to potassium. Renin-angiotensin aldosterone system inhibitors like AC inhibitors in ARB and ARNI in patients with reduced ejection fraction, New York Heart Association function class 2 to 3 symptoms, ARN inhibitor is recommended to reduce morbidity and mortality. When the use of ARNI is not feasible, AC inhibitors or ARB is recommended to reduce morbidity and mortality. The ARNI is the first class to go, but is not available. AC inhibitors or ARB. SGLT2 inhibitors are recommended in patients with symptomatic reduced ejection fractions, reduce hospitalization and cardiovascular mortality, irrespective of presence of type 2 diabetes. It's very important. Adding SGLT2 inhibitors improves cardiovascular mortality, even if they do not have diabetes. Hydralazine and isosorbide is the next class. For patients self-identifies as black or NYHA function class 3 to 4 heart failure with reduced ejection fraction who are receiving optimal medical therapy, the combination of hydralazine and isosorbide dinitrate is recommended to improve symptoms and reduce morbidity and mortality. In patients with the current or previous symptomatic heart failure with reduced ejection fraction who cannot be given first-line agents such as ARNI, AC inhibitor, or ARB because of drug tolerance or renal insufficiency, a combination of hydralazine and isosorbide dinitrate might be considered to reduce morbidity and mortality. The next group is heart failure with preserved ejection fraction. Hypertension is a major risk factor for developing heart failure with preserved ejection fraction and an important target for heart failure management to reduce hospitalization, cardiovascular events, and mortality. When you see a signs of volume overload, use diuretics. Second is renin-angiotensin aldosterone inhibitors. To attain the blood pressure, systolic blood pressure less than 130, one can use MRA, like mineralocorticoid receptor antagonist, or ARNI, or ARB when ARNI is not feasible. So the mainline agents in hypertension with heart failure with preserved ejection fraction is mineralocorticoid receptor antagonist or ARNI. Beta blockers are not recommended because of their negative chronotropic effects. SGLT2 inhibitors used frequently for heart failure with preserved ejection fraction treatment with or without diabetes to reduce the risk of hospitalization and cardiovascular mortality. In addition, it also lowers the blood pressure. Next group is atrial fibrillation. Hypertension has the highest attributable risk for the development of atrial fibrillation. It's present in more than 80% of the patient with the AF and is the most common comorbid condition regardless of age. So when you have AF, look at hypertension. Or in patients with hypertension, one should monitor for atrial fibrillations if it is not controlled well with medications and lifestyle modifications. Both atrial fibrillation and hypertension increases in frequency with age. Both increases cardiovascular disease risk. The optimal BP control reduces the rate of MAS, which is major adverse cardiovascular events, including stroke. Randomized control trial and observational studies shows MRAs, mineralocorticoid receptor antagonists, reduce atrial fibrillation burden. The control of hypertension is a key component of atrial fibrillation management. The goal, the blood pressure should be less than 130 over 80 millimeter of mercury. So it's beware checking the blood pressure and also monitoring atrial fibrillation in patient with hypertension. Next category is valvular heart disease. There are no recommendations based on sufficiently strong evidence for the management of adults with hypertension and valvular heart disease other than for aortic stenosis or chronic aortic regurgitation. Uncontrolled hypertension with aortic stenosis or chronic aortic regurgitation associated with worsening symptoms, heart failure with reduced ejection fraction, and death. AC inhibitors or ARB to achieve BP control is associated with reduced mortality. Next category is aortic diseases. Hypertension is a major risk factor for aortic disease, including thoracic aortic aneurysm, abdominal aortic aneurysm, and aortic dissection. The risk for abdominal aortic aneurysm rupture increases by 30% for each increase of 10 millimeter of mercury in BP levels. The intensive BP management, the optimal BP control is necessary in patients with aortic diseases of aneurysm and aortic dissection. The blood pressure needs to be less than 130 over 80. It reduces cardiovascular disease risk reduction in patients with hypertension with aortic disease, although the patient may be asymptomatic. So it doesn't mean that aortic diseases have to have symptomatology before you treat. Even in the absence of symptoms, one should reduce the blood pressure less than 130 over 80. Hypertension after kidney transplantation. The prevalence of hypertension is 67% to 92% among people with chronic kidney disease. Sorry, the topic is supposed to have read chronic kidney disease. Apologies. Chronic kidney disease is the important risk factor for cardiovascular disease. The treatment goal is less than 130 millimeter of mercury. AC inhibitors or ARBs recommended for initial treatment of hypertension in chronic kidney disease. These recommendations refer to patients who are not undergoing dialysis. Those patients who are in dialysis, please discuss with your nephrologist. In the non-dialysis patients, the blood pressure has to be less than 130, and preferable agents are AC inhibitors or ARB, not together, because both of them tend to increase potassium. The recommendations are as follows. For adults with hypertension and CKD, meaning GFR less than 60, albuminuria more than 30, the treatment target is systolic blood pressure of less than 130 to decrease all-cause mortality. For adults with hypertension identified GFR less than 30, albuminuria more than 30, one should use RAASI, either AC inhibitor or ARB, but not both. The next category is hypertension after kidney transplantation. Hypertension is common after kidney transplantation because of pre-existing kidney disease. Its effects of immunosuppressive medication and also presence of allograft pathology. Hypertension may accelerate kidney function decline and increases the risk for cardiovascular disease and mortality. Calcineurin inhibitors often used for immunosuppression further increases blood pressure to the extent of 70 to 90%. There is insufficient evidence to support the specific recommendations on BP targets or recommended agents for kidney transplant recipients. Next big category is cerebrovascular disease. Stroke is a major cause of death, disability, and dementia. First, we will look at acute intracerebral hemorrhage. We have done hypertension emergencies And also we have done stroke in adults and children. Please refer for further information, how to identify, how to treat, and how to follow up on it. Spontaneous non-traumatic intracranial hemorrhage is a significant global cause of morbidity and mortality. The elevated BP is highly prevalent in the setting of acute intracranial hemorrhage and is linked to greater hematoma expansion, neurological worsening, and death and dependency after intracranial hemorrhage. The recommendations are as follows. The recommendation for acute intracranial hemorrhage and acute ischemic strokes are different, and also hypertensive emergencies. For others, more or less than 130, less than 80. Okay. The class of recommendation is 2A. For adult patients with acute spontaneous intracerebral hemorrhage who present with systolic blood pressure 150 and 220 millimeter mercury, it can be beneficial to lower the blood pressure between 130 to 140 for at least 7 days after ICH to improve functional outcomes. But stop medications if the systolic blood pressure is less than 130. So these patients need to be in ICU, needs to have outline to monitor, because you need to meticulously reduce the blood pressure between 130 to 140. It has been shown if the blood pressure falls below 130 has a poor functional outcomes. The second recommendation, in adults with acute spontaneous intracranial hemorrhage requiring acute BP lowering, careful titration to ensure smooth, non-labile, and sustained control of blood pressure, avoiding peaks and large variability in systolic blood pressure. It can be beneficial for improving functional outcomes. So this patient needs to be in ICU and needs to have arterial line while you are doing blood pressure control. Third important thing, for adult patient with acute spontaneous intracranial hemorrhage with the systolic blood pressure more than 220 should not be lowered below 130 because it has a bad adverse events. The next category is acute ischemic stroke. High blood pressure occurs in about 80% of acute stroke patients. Contracting concerns about hypertension during ischemic stroke include enhancing cerebral perfusion while minimizing brain edema and hemorrhagic transformation of the ischemic tissue. So you need to have a balanced act, not to worsen the hemorrhagic transformation, but also make sure the perfusion to the affected area is maintained while you are decreasing blood pressure. So rapid reduction of BP, even to levels within the hypertensive range, can be detrimental. It's very important to follow the guidelines in acute ischemic stroke and also in intracerebral hemorrhage. The treatment of hypertension in acute ischemic stroke is dependent on the following conditions. Whether we are going to do treatment with IV thrombolysis, treatment with endovascular thrombectomy with successful reperfusion on patient with systolic blood pressure more than 220 or diastolic blood pressure more than 120, and whether they have other comorbid conditions requiring treatment. So all need to be considered while we are reducing the blood pressure. Early treatment of hypertension is indicated when required by comorbid conditions. For example, when they have a concomitant acute coronary event, acute heart failure, aortic dissection, post-fibrinolysis symptomatic intracerebral hemorrhage, or preeclampsia or eclampsia. The recommendations are as follows. Number 1, in patient with acute ischemic stroke, hypotension and hypovolemia should be corrected to maintain systemic perfusion necessary to support organ function. So that needs to be done primarily if they have hypotension and hypovolemia. Second, the patients who have elevated BP and are otherwise eligible for treatment with IV thrombolytics should have their BP lowered less than 185 and diastolic blood pressure less than 110 before IV thrombolysis is initiated, and should be maintained less than 180 over 105 for at least first 24 hours after initiating thrombolytic therapy to avoid complications. Third recommendation, in patients who undergo endovascular treatment, it is reasonable to maintain BP less than 180 over 105 during the first 24 hours after the procedure to improve long-term functional outcomes and prevent death. Fourth recommendation is based on limited data. In patients, the BP is more than 220 over 120 who did not receive IV thrombolysis or endovascular treatment and have no, no comorbid conditions requiring acute antihypertensive treatment, it is reasonable to lower the BP by 15% during the first 24 hours after the onset of stroke to improve the outcomes, because furthering below can affect perfusion to the stroke or penumbra. Recommendation 5. In patient when the BP is elevated, when the BP is less than 220 over 120, who do not receive IV thrombolysis, endovascular treatment, and do not have a comorbid condition requiring urgent antihypertensive treatment, initiating or reinitiating treatment of hypertension within 48 to 72 hours after an acute ischemic stroke is not effective to prevent death or disability. So, antihypertensive treatment needs to be initiated. All needs to be in ICU. In patients undergoing successful brain reperfusion with endovascular treatment for large vessel occlusion, lowering systolic blood pressure less than 140 within the first 24 to 72 hours after reperfusion can worsen long-term functional outcome. The next is secondary stroke prevention. Each year in the United States, 750,000 adult patients experience stroke, of which about 23% are recurrent strokes. So more than 75% of the ischemic stroke or ICH survivors have hypertension. Hypertension is the most important risk factor for stroke and ICH recurrence. Neurologically stable patients with cerebrovascular disease benefit from reducing systolic blood pressure and diastolic blood pressure less than 130 over 80. Very important. Neurologically stable patients. And that BP targets for stroke, ICH, and major vascular event. So when there is an event happens, you have to be very careful in the absence or if they are neurologically stable, bring down the blood pressure. The optimal timing for BP reduction after stroke is not clear. These are the following recommendations. In patients with hypertension who have experienced ischemic stroke, transient ischemic attack, or ICH, treatment with thiazide type diuretic, ACEI, ACE inhibitors, or ARBs recommended for lowering BP and reducing the recurrent stroke and ICH risk. In patients with hypertension who have experienced an ischemic stroke, EAA, or ICH, and the goal of blood pressure has to be less than 130 over 80 to reduce recurrent stroke, ICH, and other vascular events. In patients with no history of hypertension who have experienced ischemic stroke, TIA, or ICH, have an average systolic blood pressure more than 130 over 80, antihypertensive medication treatment can be beneficial to reduce the recurrent stroke, ICH, and other vascular events. The next category is mild cognitive impairment and dementia. Dementia affects memory and other cognitive functions, behavior functioning, and social abilities, impairing daily life and resulting in most nursing home placements. 9 million Americans could have dementia by 2030 and nearly 12 million by 2040. The prevalence of mild cognitive impairment, a transitional state between normal cognitive aging and dementia, is also expected to markedly increase. Hypertension has been identified as a prevalent modifiable risk factor for cognitive decline and dementia. It's very important. Identify hypertension early and treat them to keep it below 130 over 120, preferably less than 120 over 80. This is a recommendation. Adults with hypertension goal of less than 130 is recommended to prevent mild cognitive impairment and dementia. Next category is peripheral artery disease. Hypertension is present in 35 to 55% of patients at the time peripheral artery disease diagnosis is made. The treatment goal: reduce the blood pressure less than 130 to 80. It has been shown to reduce the risk of MACE, which is major adverse cardiovascular events, including stroke, myocardial infarction, heart failure, and cardiovascular death. Cardiovascular benefits are shown with the use of ACI, ACE inhibitors, or ARB, and these agents should be the first line for adults with peripheral artery disease and hypertension. Next category, important category, is hypertension and pregnancy. Hypertensive disorders of pregnancy strongly associated with maternal and fetal neonatal complications and are a leading cause of pregnancy-associated mortality. Hypertensive disorders of pregnancy are increasingly common in US, affecting 15.9% deliveries. It's more common among Blacks, American Indian, Alaska Native women, women aged more than 35 years, and women with obesity. Recommendations are as follows. For individuals with hypertension who are planning a pregnancy or who become pregnant, labetalol and the extended release nifedipine are preferred agents to treat hypertension and minimizing fetal risk. The second recommendation is individuals with hypertension who are planning a pregnancy or who become pregnant should be counseled about the benefits of low-dose aspirin to reduce the risk of preeclampsia and its sequelae. Third, pregnant individuals with systolic blood pressure more than 160 over 110, confirmed on repeat measurement within 15 minutes, should receive antihypertensive medication, which we are going to talk about, to lower the blood pressure less than 160 over 110 within 30 to 60 minutes to prevent adverse effects. The pregnant individuals with chronic hypertension, meaning hypertension was identified prior to 20 weeks, according to ACOG 140 to 159 over 90 to 109, should receive antihypertensive therapy to achieve BP less than 140 over 90 to prevent maternal and perinatal morbidity and mortality. Fifth recommendation. Individuals with hypertension who are planning a pregnancy or who become pregnant should not be treated with atenolol, ACE inhibitors, ARB, direct renin inhibitor, nitroprusside, or MRI to avoid fetal harm. So in pregnancy, the kind of medication what you can use is very, very restricted, which is very different from what we use outside pregnancy. These are the classification of hypertensive disorders of pregnancy. One is chronic hypertension, the diagnosis of hypertension prior to pregnancy or less than 20 weeks of gestation. Second is gestational hypertension. It's de novo hypertension when the pregnancy is more than 20 weeks, in the absence of proteinuria or other signs of preeclampsia. Third is preeclampsia, gestational hypertension with proteinuria or other maternal end organ dysfunction, including neurologic findings, pulmonary edema, hematologic findings, and acute kidney injury, hepatic dysfunction. The third category is preeclampsia superimposed on chronic hypertension. Preeclampsia in a woman with history of hypertension before pregnancy or before 20 weeks of gestation comes under preeclampsia superimposed on chronic hypertension. Gestational hypertension, as we discussed, hypertension developing after 20 weeks of gestation in the absence of new proteinuria or target organ damage. Gestational hypertension is associated with an increased risk of maternal, fetal, neonatal adverse events. End up to 30% of women with gestational hypertension ultimately develop preeclampsia. Gestational hypertension carries higher risk of future hypertension. The development of severe hypertension is associated with an increased risk of pregnancy loss, NICU admission, preterm delivery, and low birth weight. So hypertension, whether it is gestational or chronic hypertension or preeclampsia, they all have a bad effect on maternal, neonatal, and fetal outcomes. According to ACOG, which is American College of Obstetricians and Gynecologists, the diagnostic criteria for hypertension in pregnancy. Hypertension in pregnancy defined when the systolic blood pressure is more than 140 over 90. Severe range hypertension, systolic blood pressure more than 160 over 110. What are the common oral antihypertensive agents used in pregnancy? As we mentioned earlier, 4, which is very different from other categories and another year outside pregnancy, what we use, the first line agents, thiazide antidiuretics, AC inhibitors, ARBs, and dihydropyridine calcium channel blockers. Here, labetalol, 200 to 2400 milligram per deciliter orally in 2 or 3 divided doses, commonly initiated at 100 to 200 milligram twice daily. It has potential bronchoconstrictive effects. Avoid in women with asthma, pre-existing myocardial disease, decompensated cardiac function, and heart block and bradycardia. Nifedipine, the dose 30 to 120 milligram per day, orally of an extended release preparation, commonly initiated at 30 to 60 milligram once daily, extended release. Do not use sublingual form or nifedipine because it causes precipitous drop in the blood pressure. Immediate release formulation should generally be reserved for control of severe, acutely elevated blood pressure in hospitalized patients. It should be avoided in tachycardia. Methyl dopa 500 to 3000 milligram per day orally in 2 to 4 divided doses. It's commonly initiated at 250 milligram 2 or 3 times daily. The safety data up to 7 years of age in offspring may not be as effective as other medications, especially in control of severe hypertension. Use limited by side effect profile like sedation, depression, and dizziness. Hydrochlorothiazide 12.5 to 50 milligram daily. This is second or third line agents. The first line agents in pregnancy are labetalol, nifedipine, methyl dopa. What are the antihypertensive agents can be used for urgent blood pressure control in pregnancy? What we discussed was oral. Now it is IV preparations. Labetalol, 10 to 20 milligram IV, then 20 to 80 milligram every 10 to 30 minutes to a maximum cumulative dosage of 300 milligram, or constant infusion 1 to 3 milligram per minute IV. Tachycardia is less common with the fewer adverse effects with the labetalol. Avoid in women with asthma, pre-existing myocardial disease, decompensated cardiac functions, and heart block and bradycardia. The onset of action is 1 to 2 minutes. There is an advantage of labetalol. Hydralazine is a vasodilator. 5 milligram IV or IM, then 5 to 10 milligram IV therapy every 20 to 40 minutes to a maximum cumulative dosage of 20 milligram, or constant infusion of 0.5 to 10 milligram per hour. Higher or frequent doses associated with maternal hypertension, headaches, and abnormal fetal heart rate tracings may be more common than other agents. The onset of action is 10 to 20 minutes. Nifedipine, immediate release, 10 to 20 milligram orally, repeat in 20 minutes if needed, then 10 to 20 milligram every 2 to 6 hours. The maximum daily dose is 180 milligram. You may see reflex tachycardia and headaches. The onset of action is 5 to 10 minutes. The next category preeclampsia and eclampsia, including preeclampsia superimposed on chronic hypertension. Preeclampsia is a multi-organ system inflammatory syndrome, is an hypertensive disorders of pregnancy characterized by hypertension as well as proteinuria or target organ dysfunction. It develops in 20 to 50% of individuals with chronic hypertension. So when you have chronic hypertension, you should use, well, you need to identify or check them very frequently, and also you can do low dose aspirin to prevent the development of preeclampsia. The other category is called HELP syndrome. HELP syndrome, wherein there will be a preeclampsia, severe features of hemolysis, elevated liver enzymes, and low platelet count. It is associated with HELP syndrome, associated with increased rates of maternal and fetal neonatal morbidity and mortality. Eclampsia, the occurrence of convulsive seizures, one of the severest forms of preeclampsia. So preeclampsia with seizures called eclampsia. Both preeclampsia and eclampsia can occur before, during, or after delivery. How do you treat? Max sulfate in addition to antihypertensive medication that we have discussed earlier. So diagnostic criteria for preeclampsia, as we mentioned earlier, you need to have hypertension, which is more than 140/90 in 2 occasions for 4 hours apart after 20 weeks of gestation. Or women with previously normal BP with a systolic blood pressure of 160/110, confirmed within short interval time to facilitate timely antihypertensive therapy. And blood pressure with proteinuria, which is more than 300 milligram per 24-hour urine collection, or protein creatinine ratio more than 0.3, or dipstick reading more than 2+ and above. Or in the absence of proteinuria, new onset hypertension with the new onset of any of the following, like thrombocytopenia, platelet count less than 100, renal insufficiency, creatinine concentrations more than 1.1 milligram per deciliter, or doubling serum creatinine concentration in the absence of other renal disease, impaired liver function, meaning elevated blood concentration of liver transaminases or twice normal concentration, and having pulmonary edema, new onset headache, responsive to medication, not accounted for by the alternative diagnosis or visual symptoms. Short and long-term follow-up of pregnancy-associated hypertension. ACOG recommends BP check for individuals with HTP within 3 to 10 days of discharge. It's preferable to send them on home BP monitoring because that will have a better BP control. Early detection, diagnosis, and management of hypertension in this high-risk group is very essential. So early identification and home blood pressure monitoring will help prevent catastrophic consequences. Those who have resolved blood pressure after HDP, still the BP needs to be monitored annually. With no medical contraindications, individuals with history of HDP should be educated of low-dose aspirin and prescribed low-dose aspirin at 12 weeks of gestation during subsequent pregnancies, that is to prevent preeclampsia. The next category is resistant hypertension and renal denervation. Resistant hypertension is defined as BP above goal despite treatment with 3 antihypertensive medications with complementary mechanisms of action, including diuretic at maximally tolerated doses, or BP to goal occurring more than 4 medications. Based on the current BP goal of less than 130/80, the prevalence of resistant hypertension is approximately 8.5 to 20% among hypertensive US adults. It is very huge. The common risk factors for resistant hypertension are older age, obesity, chronic kidney disease, and diabetes. The patients with resistant hypertension are known to have at least 50% higher risk of myocardial infarction, stroke, end-stage kidney disease, and cardiovascular death than adults with hypertension without resistant treatment. So if you have developed a resistant, 50% chance of cardiovascular or MACE. Renal denervation is an additional option to consider in resistant hypertension. In the absence of antihypertensive medications, renal denervation induces reduction of BP in 24-hour or daytime ambulatory systolic blood pressure by 4 to 6 millimeters of mercury during a follow-up duration of 2 to 3 months. Renal denervation should not be considered as a curative therapy. It is a adjunctive therapy. Recommendations are as follows for resistant hypertension. In adults with resistant hypertension, a more detailed evaluation for secondary causes to include careful review of all medications, removal of those with interfering with the effects on BP, but beneficial for lowering BP and simplifying treatment. It's very important. Relook at everything when the patient is not responding to your first line and second line medications. In adults with uncontrolled resistant hypertension, despite optimal treatment with the first line antihypertensive therapy, that is ACE or ARB plus CCB and thiazide-like diuretics, with a GFR more than 45 ml, addition of MRA is recommended to control. So if you have those four, you can add MRA along with it. Third recommendation is in adults with uncontrolled resistant hypertension who cannot tolerate or have a contraindication to MRA, the addition of one of the following agents or classes like amiloride, beta blockers, alpha blockers, central sympatholytic drugs, dual endothelin receptor antagonists, or direct vasodilators are reasonable to control blood pressure. In carefully selected patients with systolic diastolic hypertension, meaning 140, 280 over 90, with a GFR more than 40 ml, who have resistant hypertension despite optimal treatment or intolerable side effects to additional antihypertensive drug therapy, renal denervation may be reasonable as an adjunct treatment to BP medication and lifestyle modification to reduce BP. So it's a restricted use, but there is a role for RDN. The fifth recommendation is all patients with hypertension who are being considered for RDN should be evaluated by multidisciplinary team. The sixth recommendation is for patients with hypertension for whom RDN is contemplated, the benefits of lowering BP and potential procedural risk compared with continuing medical therapy should be discussed as a part of shared decision-making process to ensure patients choose a therapy that meets their expectations. So what is the selection criteria used for renal denervation? 1. The patient with a stage 2 hypertension, meaning systolic blood pressure more than 140, diastolic blood pressure more than 90, in whom BP is not at goal despite more than 4 antihypertensive medications at optimal dosages, AC inhibitors / ARB plus CCB, thiazide diuretics plus MRA. That is one indication for renal denervation. The second, patients with stage 2 hypertension who are unable to take antihypertensive medication at the optimal dosages for different reasons. And also one should consider contraindications when you are doing renal denervation, like the patient should not have neurogenic orthostatic hypertension, pregnancy, fibromuscular dysplasia, stented renal artery aneurysm, significant renal artery stenosis, and known kidney or secreting adrenal tumors. So number 1, confirm the resistance. Number 2, exclude pseudo-resistance, because sometimes BP is elevated at the office, so on and so forth. Third, identify and reverse contributing lifestyle factors. Fourth, discontinue or minimize interfering substances. Fifth, screen for secondary causes of hypertension. Sixth, pharmacological treatment. Maximize diuretic therapy, add spironolactone or eplerenone, use chlorothalidone or loop diuretics in CKD. stage 4 or greater, and agents with different mechanism of action like beta blockers, central sympatholytic drugs, non-hydropyridine CCB for elevated heart rate, and add potent vasodilators like aprocitentan, hydralazine, or minoxidil only for already on beta blockers and loop diuretic. And refer to a specialist who is well versed with renal denervation. The complications of management. The recommendation for orthostatic hypertension. In adults with hypertension, improved BP control is recommended to reduce the risk of orthostatic hypertension. In adults receiving intensive BP lowering therapy with asymptomatic orthostatic hypertension, treatment with the goal of systolic blood pressure less than 130 is reasonable due to increased cardiovascular disease and mortality benefit. Third recommendation, in adults with hypertension, initiating treatment or adding medication with the goal of systolic blood pressure less than 130, assessment of symptomatic orthostatic hypertension is reasonable to detect other chronic conditions. Next is hypertension emergencies and severe hypertension in non-pregnant and non-stroke patients. As we already discussed, non-pregnant is completely different category, different ACOG recommendations. Non-stroke patients, again, there are two categories, ICH and acute ischemic stroke. They have a different recommendations. In the absence of those ones, in adults with hypertension emergency, meaning BP is more than 180 over 120, evidence of acute target organ damage, admission to an intensive care unit is recommended for continuous monitoring of BP and target organ damage and for consideration of parenteral administration of appropriate therapy. Second, recommendations. For adults with hypertension emergency related to compelling conditions like acute aortic syndrome or acute aortic dissection, systolic blood pressure should be reduced less than 140 for most conditions and to less than 120 for aortic dissection during the first hour while monitoring for other target organ dysfunction. Third recommendation is for adults with hypertension emergency but without compelling conditions, without aortic diseases. Systolic blood pressure should be reduced by oral or parenteral therapy by no more than 25% within the first hour. Then, if stable, less than 160 over 100 millimeter of mercury within the next 2 to 6 hours. Then cautiously 230 to 140 during the next 24 to 48 hours to limit target organ injury. At that point, the target organs are used to have high blood pressure, so bring down slowly as recommended here. Fourth recommendation, for adults with severe hypertension, meaning more than 180 over 120, who are hospitalized for non-cardiac conditions without evidence of acute target organ damage, intermittent use of additional IV or oral antihypertensive medications are not recommended to acutely reduce blood pressure. We'll go on by one. Calcium channel blockers, dihydropyridine. The drugs used often are nicardipine or clavidipine. Nicardipine drip initially start at 5 mg per hour, increase every 5 minutes by 2.5 mg per hour to maximize 15 mg per hour. You need to know contraindications such as advanced aortic stenosis. No dose adjustment needed for persons aged more than 65 years. Clavidipine, initial 1 to 2 mg per hour, double every 90 seconds until BP approaches target, then increasing by less than double every 5 to 10 minutes. Maximum dose of 21 mg per hour. Maximum duration is 72 hours. It's contraindicated in patients with soybean, soy product, egg product allergy, and in patients with a defective lipid metabolism, pathological hyperlipidemia, lipoid nephrosis, acute pancreatitis. No negative inotropic or chronotropic effects, decreased risk of reflex tachycardia with clavidipine. Vasodilators often used are sodium nitroprusside, nitroglycerin. Initial dose of nitroprusside 0.3 to 0.5 mics per kg per minute, increase in increments 0.5 mics per kg per minute every 5 minutes to achieve PP target. Maximum dose is 10 mics per kg per minute. The duration of treatment is as short as possible. Next group is nitroglycerin. Initiate 5 mics per minute, increase in increments 5 mics per minute every 3 to 5 minutes to maximum of 200 mics per minute. Next is hydralazine vasodilators, direct vasodilators. Initial 10 milligram via slow IV infusion, maximum dose is 20. Repeat every 4 to 6 hours as needed. Adjust the rate up to total cumulative dose of 200 milligram in 24 hours. Adrenergic blockers, beta-1 receptor selective antagonists, esmolol. Loading doses of 500 to 1000 mics per kg per minute over 1 minute, followed by 50 mics per kg per minute infusion. For additional dosing, the bolus is repeated. The infusion increased to 50 mics per kg per minute increments as needed to the max of 300 mics per kg per minute. Adrenergic blockers combined alpha-1 and non-selective beta receptor antagonist, labetalol. Initial 0.3 to 1 milligram per kg dose, max of 20. Slow IV injection every 2 minutes, or 0.4 to 1 milligram per kilogram per hour IV infusion up to 3 milligram per kg per hour. Adjust the rate up to total cumulative dose of 300 milligram in 24 hours. Next category is adrenergic blockers, non-selective alpha receptor antagonists like phentolamine. IV bolus dose of 5 milligram, additional bolus dose every 10 minutes as needed to lower BP to target. Adjust rate up to total cumulative dose of 50 milligram per hour. This is used hypertensive emergencies associated with catecholamine excess, pheochromocytoma, interaction between MAO inhibitors and other drugs of food, cocaine toxicity, amphetamine overdose, or chloride withdrawal. Otherwise, phentolamine is not used except in those particular situations, typically hydralazine, esmolol, labetalol, and other drugs we discussed before. Dopamine 1 receptor selective agonist, pheneldiprine, 0.1 to 0.3 mics per kg per minute, increased to 0.05 to 0.1 mics per kg per minute every 15 minutes until PP is reached. The maximum infusion rate is 1.6 microgram per kg per minute. AC inhibitors, enlaprolate. Initial 1.25 milligram over 5-minute period. Doses can be increased up to 5 milligram every 6 hours as needed to achieve BP target. Adjust the rate up to total cumulative dose of 50 milligram in 24 hours. Intravenous antihypertensive drugs in selective comorbid conditions. For example, in acute aortic dissection, esmolol, labetalol is preferred. Acute pulmonary edema, clavidipine, nitroglycerin, or nitroprusside. Acute coronary syndrome, esmolol, labetalol, nicardipine, and nitroglycerin. Acute kidney injury, clavidipine, pheneldiprine, and nicardipine. Eclampsia and preeclampsia, hydralazine, labetalol, nicardipine, and nifedipine. Preoperative hypertension, meaning BP more than 160 over 90, clavidipine, esmolol, and nicardipine, nitroglycerin. Acute sympathetic discharge or catecholamine excess states, clavidipine, nicardipine, and phentolamine. Acute ICH, intracerebral hemorrhage, clavidipine, nicardipine, esmolol, labetalol, and hydralazine. Acute ischemic stroke, same medications. But the target blood pressure levels are different in intracerebral hemorrhage and acute ischemic stroke. Sexual dysfunction frequently occurs in patients with hypertension because of hypertension by itself. It's reported by women than in men. What is sexual dysfunction? Less thoughts and desires, less arousal, less frequency of sexual activity, less pleasure in orgasm, and problems affecting sexual function. The association between hypertension and sexual dysfunction, impaired vascular function, and atherosclerosis. The common risk factors are increasing age, hormonal shifts, diabetes, and depression. The antihypertensive medications may also contribute sexual dysfunction. Diuretics and beta blockers are notable, except nebivolol can associated with erectile dysfunction. ARB is the most favorable profile in men and women. Phosphodiesterase 5 inhibitors are safe along with other antihypertensive medication, but caution should be exercised when you use phosphodiesterase inhibitors along with diltiazem or ingested with grapefruit juice, alcohol, which may increase the risk of hypertension. These drugs should not be taken with nitrates due to the risk of severe hypertension. The patient schedule for surgical procedures. Hypertension associated with procedures, especially cardiovascular and cerebrovascular events, and bleeding if it is not detected and treated properly. 25% of the patients who undergo major non-cardiac surgery and 80% of the patients who have cardiac surgery experience perioperative hypertension. The level of risk can be related to the severity of hypertension. The abrupt cessation of certain medications like beta blockers and clonidine can associated with rebound hypertension. So important to assess whether the high blood pressure is because of volume status, pain control, oxygenation, and bladder distension. The recommendations are as follows. In patients with hypertension scheduled for major surgery should have been on beta blockers chronically. Beta blockers should be continued throughout the throughout the perioperative period to assist BP control. That is number one. There is no abrupt cessation needed in beta blockers. Second, in patients with hypertension scheduled for elective major surgery, it is reasonable to continue most medication for hypertension throughout the perioperative period. Third, in patients with hypertension scheduled for major surgery, discontinuation of AC inhibitors, ARB perioperatively, may be considered to prevent hypotension during surgery. Only AC inhibitors and ARB can be considered to be discontinued. Fourth, in patients scheduled for elective major surgery with systolic blood pressure more than 180, diastolic blood pressure more than 10, deferring surgery may be considered, especially in high-risk patients, to minimize perioperative complications. 5. In patients with hypertension scheduled for surgery, abrupt preoperative discontinuation or clonidine result in rebound hypertension, so it should not be done. 6. For patients with hypertension scheduled for surgery, beta blockers should not be started on the day of surgery in beta blockers naive patients because of increased risk of post-operative mortality. So you have to be very careful in these harm categories. Finally, severe hypertension and hypertension emergencies. When the blood pressure is more than 180 over 120, look at whether the patient has acute target organ damage. If it is present, it is called hypertension emergency. If it is not present, it is called severe hypertension. Then, whether the hypertension was identified in emergency department or outpatient setting. If you have an acute organ damage, admit the patient in ICU. Let's look at the less severe one. Inpatient in the emergency department, evaluate for whether to admit or outpatient treatment, depending on the indications other than blood pressure alone, other comorbid factors. Avoid parenteral BP lowering therapy or intensified oral therapy in the acute settings. Don't do that. You need to have a monitoring. In outpatient setting, no need to refer to emergency department, reinstitute, intensify or modify medical therapy in the outpatient setting. Close follow-up is needed in the outpatient setting in 4 weeks. The other category, severe category, look at aortic dissection or pheochromocytoma crisis. If it is yes, reduce the blood pressure. If it is aortic dissections, reduce to less than 120. pheochromocytoma crisis, reduce the systolic blood pressure less than 140 in the first hour. If it is not there, reduce the systolic blood pressure 25% in the first hour and to 160 to 100 to 110 over next 6 hours, then to normal in the next 24 to 48 hours. These are all based on American Heart Association and American College of Cardiology Foundation. This concludes the presentation on 2025 high blood pressure and hypertension guidelines by American Heart Association and American College of Cardiology, Part 3.